Good evening to everyone present here with us today. This is Shreyan from IGCP. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor, Dr. Abhay Sahu. Sir is MBBS from MKCG Medical College, MD of General Medicine from BHU, DM Endocrinology and Metabolism, AIMS New Delhi. Sir is professor at the Department of Endocrinology and Metabolism at IMS and SUM Hospital, Kalinga Nagar, Bhubaneswar, Orissa. Sir is also a senior consultant at Apollo Hospital, Bhubaneswar. With the help of Sir and his wonderful insight, we will be taking a close look on today's aspect, which is juvenile hypothyroidism and its typical presentation. Now, without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him. Over to you, Sir.
Yeah. Thank you, Sayan. Today, dear friends and colleagues, today we are going to discuss juvenile hypothyroidism and what are the peculiarities and what are the challenges we face. As an endocrinologist, the most common endocrine disorder what we see in clinical practice is diabetes. After that, probably the most common cause or the most common type of abnormalities what we see in the clinical practice is hypothyroidism. If we take the prevalence of hypothyroidism in the general population, it is in the range of 2 to 3%. And if we take only the female population, probably it is as high as up to 8 to 9%. So, looking at the proportion of people who are being suffered by the hypothyroidism. So, today we are going to discuss a typical subject, juvenile hypothyroidism, and what are the classical peculiarities and what are the challenges what we face when we see such type of hypothyroidism. So we know this is the most common, hypothyroidism is the most common thyroid dysfunction among children. And once we are discussing juvenile hypothyroidism, probably the acquired hypothyroidism is the most common type of hypothyroidism. We are not discussing about the congenital hypothyroidism. And once we are discussing about juvenile hypothyroidism, it could be either a subclinical hypothyroid, it could be overt hypothyroidism. And what it has a lot of impact not only on the as a clinical pictures, but it has a lot of impact on the skeletal growth and maturation, impact on the pivotal development, and also impact on the scholastic performance of the people. We know that unlike adults, there are very classical typical presentation in the adults, but in children, there is a quite variable presentation, and hence early diagnosis and treatment is crucial in those group of patients. If we see the prevalence, as I have discussed in India, there is a positive data of juvenile hypothyroidism in the children, but there are two studies. We know that from the Eastern India, Sanjit et al. Has taken almost 100 participants. 74% was 100 participants of those who are detected as hypothyroid. Out of that, 74% is overt hypothyroid, and only 26% is found to be subclinical hypothyroid. And most important part is close to 66% people are female. The average age of their presentation was 9 plus minus 3 years. And in the overt hypothyroid group, it is 8 plus minus 3 years. Again, there is another study from the South India by Gopal et al., which has shown the subclinical hypothyroid and overt hypothyroidism in the range of 4% and 3% respectively. And subclinical hypothyroidism was much more prevalent in adolescent, and overt hypothyroidism is much more common in children than adolescent in their typical presentation. Let us see what are the most common etiology what we see. If we will see the primary hypothyroidism, then Hashimoto's thyroiditis is the most common cause. Of course, the external radiation to the head and neck, radiation therapies for particular hypothyroidism, post-thyroidectomy, certain drugs which can cause hypothyroidism like interferon alpha, lithium, and iodine-containing drugs. There are certain metabolic disorders like cystinosis and mitochondrial disorders. They can also produce primary hypothyroidism. And if we discuss secondary hypothyroidism, there are certain developmental defects like pituitary stalk interruption, And there are tumors or infiltrative disorders. They can infiltrate the particular pituitary gland and they can produce secondary hypothyroidism. And of course, those areas where iodine deficiency is one of the important factor, there again iodine deficiency is one of the important cause. But in India nowadays, iodine deficiency is quite uncommon in our population. Not only it is the classical age I have discussed, the atypical presentation. So there are a lot of syndromes which actually associated with hypothyroidism. So if you are diagnosing Dijor syndrome, Prader-Willi syndrome, or Williams syndrome, they can have a late presentation as a congenital hypothyroidism. Again, hypothyroidism in cancer survivors, we know that once there is radiation to the head and neck, that in the latter stage they can produce hypothyroidism. So up to 30% of the cancer survivors, they usually develop some sort of primary hypothyroidism. Again, annual TSH screening and usually next screening is utmost important, and they should start 5 years after radiation therapies. If we'll discuss acquired central hypothyroidism, then it is associated with classically with other hormone disorders. Of course, it is rare. If we'll take as a part of hypothyroidism, heart rate will be less than 1% of the total hypothyroid patients. They usually gives a history of associated trauma, tumor, meningitis, cranial irradiation, or some sort of developmental delay. And usually this patient presents, 30% of them may have normal thyroid function test at birth, but in due course of time, within few years, they present with central hypothyroidism during the follow-up period. And classically, if you'll see the evaluation, then clinical, there will be thyroid function test is utmost important. Then you should know the clinical signs and symptoms. There should be a physical examination. There could be acute illness, goiter or growth hormone assessment should be there. One should have a iodine status. What are the medications patient eating? What are the laboratory and diagnostic imaging? These are the utmost important ones we are discussing or evaluating a case of juvenile hypothyroidism. And this is the normative data for juvenile hypothyroidism, because if you'll see, there is a age-specific normative data is there. Age younger children tend to have a slightly higher serum T3 and TSH. Higher T4 turnover in this group is relative to that in the adults. So normally in the elderly adolescent group, usually T4 and TSH is bit higher in comparison to the elderly or the adults. So you might have a little bit higher TSH and T4 in comparison to the adult population. What are the evaluations we should do as an imaging process? The most common is ultrasound. We know that because here we can see a solitary nodule, you can see a ectopic location of the thyroid gland. Again, a growth trajectory, or if someone is having a proper follow-up, then you can have a growth chart. This growth chart can give us an idea where there is a deceleration of growth or where there is a stunting of growth, and that will give the beginning of the hypothyroid in those group of patients. Again, X-ray of the wrist joint to know the bone age also gives some sort of idea whether the bone age is delayed or normal or advanced. Then in some cases, there occurs a reversible enlargement of cilia, because those having persistent primary hypothyroid, they can cause a significant enlargement of the cilia due to secondary hyperplasia of the thyrotropes, and that can see in the X-ray that you can see a larger enlargement of the cilia. MRI pituitary in dynamic contrast sometimes can give a enlargement of the cilia in the central hypothyroidism. Again, regarding the screening, all symptomatic patients should be screened, whereas in asymptomatic patient, where one should go for screening, that is most important, because a lot of the times asymptomatic people come to us in our clinical practice. There are certain associations or conditions where we should advise the patient to go for thyroid function test. This is like if someone is having other autoimmune conditions like celiac disease, type 1 diabetes, or autoimmune polyendocrine syndromes. If there are certain genetic syndromes, as I have discussed, Turner's, Down, Dijor's, or Prader-Willi is there, post head and neck irradiation cases, or patient is a known case of hypopit, then in that case also one should go for central hypothyroid. Again, a false positive infant with TBG deficiency, who might get a false positive. Again, patient, those who are having sick children admitted to the ICU, then in that case you might get a false negative. Certain drugs like dopamine and glucocorticoids also, they can give a false negative test if someone is on that drugs. Again, there are combined TSH and T4 approach. This is the ideal screening if FT4 is ideal in patients with TBG deficiency. For follow-up of central hypertension, there are two conditions where combined TSH and T4 approach is required. It is thyroid binding globulin deficiency and patient who is having central hypothyroidism. Again, anti-TPO antibody is another important factor which plays a critical role or allows us to think about autoimmune etiology of this disease. Again, if someone is having a subclinical hypothyroidism, patient with elevated TSH and normal T3, T4 values, in that case, a mild elevation between 5 to 10 has less chance of progression and routine treatment is sometimes not warranted. But if someone is having a goiter, if someone is having a TPO antibody positive, then probably these are the conditions where one should start treatment without delay. And if there is no goiter, if TPO is negative, then a follow-up TSH and FT4 should be done after 6 to 12 months. If again TSH is showing a rising trend, suppose in the baseline it was 6 or 7, after 6 months it has increased to 8 or 9, probably again this is the subgroup where one should start treatment or one should give some sort of therapies in those group of patients. Again, if you see the varied clinical manifestations or diagnostic challenges, we'll discuss some of the cases, interesting cases, which will help us or makes us to think about diagnosis about the disease. So this is a case, a 12-year-old girl having a disproportionate short stature. Patient is short stature, having no goiter. On lab test, his hemoglobin is 9. At the age of 12 years, you see the total cholesterol 397. It is very high. If you see the anti-TTG antibody, tissue transglutaminase antibody is negative, that means patient is having no celiac disease. T3, T4 is very low. TSH is more than 100 and TPO antibody is positive. So it is a case of classical case of primary hypothyroidism. You see MRI is showing pituitary hyperplasia and again skull is showing enlarged ciliator shiga. There is dill bone age is significantly delayed. Ultrasound showing atrophic Hashimoto's thyroiditis. So it's a pituitary hyperplasia resolves with treatment. You see, after treatment, there is a significant improvement in the pituitary disorder. So this is a pituitary pseudomacroadenoma. It classically occurs in patient of severe primary hypothyroidism. In the long-standing primary hypothyroidism, it remains untreated. There might be enlargement of cilia. You see, here the cilia is enlarged, here the cilia is enlarged. But after treatment, you see it comes to the absolutely normal. So this is pituitary pseudomacroadenoma. So here again another patient, precocious pseudopuberty, a 17-year-old guard, short stature, developed with thilakia and menarche. That is breast budding and also started developing periods at the age of 7 years. And physical examination showing patient is having pallor, facial puffiness, and there is no thyromegaly. And SMR classification is P1 and B3. There is a non-tender large mass was palpable in the lower abdomen. If you see the thyroid, again T4 is less than 4. Normally 6 to 13 microgram per deciliter and TSH is 40. TPO antibody is positive. Again, this is a case of primary hypothyroidism with precocious pseudopuberty because we know primary hypothyroidism sometimes can cause a large ovarian cyst and that is autonomous. And one should start treatment, probably the ovarian cyst comes down to normal and there will be no recurrent pervaginal bleeding and the periods usually normal. Their breast development also comes down to normal. So there is a slow resolution of cyst and patient start developing catch-up growth. So this is the thing precocious pseudopuberty in the classical case. You see the cyst, large cyst in the ovary. So again, if you see the profound hypothyroidism in puberty, so sometimes it can cause delayed puberty, which is most common, and which is associated with short stature. Sometimes may present with pituitary pseudomacroadenoma. Levothyroxine causes a rapid progression of growth velocity and final short stature. Hence, those should be slow and gradually bump up so that there should not be a accelerated premature closing of the epiphyseal bone. Pseudoprecocious puberties, or sometimes this is called VWGS syndrome. This is usually short stature, delayed bone age, and there is a cross reaction between TSH and FSH receptor. This class develops thilarchy, ovarian enlargement, and that's a menarche. Boys sometimes they develop macrotestis without villation. So a prompt and early diagnosis can be held, unavoid unnecessary investigations and patient's anxiety and treatment, and that leads to a early treatment. Another case, 12-year-old girl having thilarchy, 3T4 is high, TSH is low. was started with levothyroxine 50 by primary physicians, later presented with altered sensorium, shock and hypoglycemia. Then cortisol is 30 nanogram per liter. So diagnosis is now it is FT4 is low, TSH is borderline normal or borderline low with low cortisol. So this is central hypothyroidism with secondary adrenal insufficiency. So they need a replacement with steroid, then subsequently levothyroxine, so that there will be no adrenal crisis. And this is the reason this is central hypothyroidism with adrenal crisis. Then another, obesity is a cause effect. A 13-year-old girl, BMI is 24. There is no thyromegaly. There is no family history of thyroid disorders. Thyroid FT4 is normal. TSH is normal. Anti-TP is negative. What is the plan? So sometimes increase in weight causes a leptin-mediated increase in TSH. It corrects with weight loss. So if someone is having a borderline elevation of TSH, one should not attribute this weight gain is due to TSH. Just as weight loss program can make the thyroid TSH normal. So any sort of obese patient, a lot of the time we have seen primary care physician starts thyroid replacement just seeing the obesity. So this is absolutely not true. If someone is having a borderline elevation of TSH, probably you should wait. You should help the patient to reduce the weight. Once there is a weight reduction, probably the TSH will be normalized. This is another child, Kocher-Debris Semaglutide syndrome. This is a 4-year-old male. Growth failure, motor milestone is delayed, and there is calf hypertrophy is there. TSH is more than 100, and if you see CPK, it is 1000. So all this calf muscle pseudohypertrophy, or this is called glycosaminoglycan deposits. This mimics muscle dystrophies, and usually with replacement of thyroid, all those glycosaminoglycans comes out, and usually the muscle pseudohypertrophy comes down, CPK comes to normal. So this is pseudohypertrophy that classically turns in the primary hypothyroidism. Then another, this is a 10-year-old boy presented to the cardiology department with severe dyspnea, having cardiac tamponade, massive pericardial effusion, chest X-ray 2D echo showing pericardial effusion, immediate pericardial synthesis done, workup showing TSH 100. So you started with replacement of thyroid, effusion resolved, again patient become normal, and again thyroid function also comes down to normal. So again, that is important thing, a massive pericardial effusion. If pericardial effusion is one of the symptoms which classically found in this group of juvenile hypothyroid cases. Another person, 10-year-old boy, septic shock, referred to PT4 is 18 nanomole per liter, TSH is 9.2. There is no goiter and no history of thyroid illness. What is the plan? This is called sick euthyroid syndrome or non-thyroidal illness syndrome. Usually in this case, there is no need of giving any thyroid replacement. You just wait and help the patient, give antibiotics, help the patient from the recovering from the septic shock. Within 4 to 8 weeks, the actually thyroid become normal. So again, those who are having septic shock, a mild alteration of the thyroid does not warrant starting thyroid replacement in those group of patients. So this is the reverse T3 in those cases increases and T3, T4 comes down. So usually this is a case of low T4 and high TSS initially, and subsequently both T3, T4 comes down. And in serious cases, sometimes TSS also comes down. If all T3, T4 come low, TSS low, probably the prognosis is poor in septic shock cases. So this is a case of non-thyroidal illness syndrome. Another person, 14-year-old guy, primary hypothyroid, on levothyroxine 250 microgram. Patient is compliant to treatment. Despite of taking levothyroxine 250, TSH is found to be 66. TPO is anti-TPO antibody is strongly positive. Hemoglobin is low, and TTG is also high, and patient is requiring very high doses. And the most important part is here, the TTG gave a clue that patient is having celiac sprue, so there is malabsorption syndrome. So patient is taking the medicine, but it is not getting absorbed. So you just treat the celiac sprue or you treat the celiac disease by avoiding all those things containing, we know that gluten containing thing diet, you just avoid that, automatically the requirement comes down, automatically the TSH will be normal. So this is autoimmune disorders like type 1 diabetes, Addison's disease, autoimmune polyendocrine syndromes, Down syndrome, Turner syndrome, they might be associated with celiac disease. So one should have kept in mind, if a primary hypothyroid patient keeping or requiring a very high dose of replacement, probably one should keep in mind the celiac disease, and that will give a clue for very high requirement. Another important thing is adherence. hypothyroid patient, FT4 is little high, TSH is still high. In that case, one should check the adherence and reactions because FT4 is high, TSH is high, then that means the compliance is poor. So if TSH is high, FT4 is low normal, then it is planned to increase the dose. FT4 high, TSH high, then check the adherence. If TSH is low and FT4 is high, then reduce the dose. So this is the plan of management for particularly adherence point of view. Then again, complication with treatment. 12-year gal diagnosed with primary hypothyroid, started with levothyroxine 100 mics. After 3 weeks, patient present with severe headache and irritability. On examination, patient is having papilledema. So sometimes with thyroid replacement, patient develops benign intracranial hypertension or pseudotumor cerebri. You start very low dose, gradually bump up the dose over a period of few months, then automatically that pseudotumor cerebri comes down, and that will help the patient for recovering from the symptoms. Then last but the least, I will discuss only 1-2 cases. This is the 10-year-old boy. The patient is having a attention deficit disorder, having normal growth percentile, normal physical examination, and lab test is showing persistent elevation of TSH despite of elevated levothyroxine. And after ruling out other causes, patient was levothyroxine was stopped. TSH was reassessed with particularly PEG precipitation. This is the way because there are a lot of heterophile antibodies that they are which interferes with the assay. So PEG precipitation was done, and patient was on biotin supplementation. Biotin stopped for 2 days prior to test. Automatically everything become normal, and so that is the things because a lot of the things like biotin they interferes with assay, they give a false positive result. So you have to stop biotin for 2 to 3 days. Automatically the thyroid comes to normal. So the treatment goal is to restore normal growth and development, including pivotal development. Levothyroxine is recommended as treatment for children with central hypothyroid, primary hypothyroid, or subclinical hypothyroid with TSH more than 10. If someone is having TSH between 5 to 10 with goiter, with TPO antibody positive, then probably they want treatment. But if TPO negative, there is no goiter, they can follow up. In follow-up, if TSH is showing a rising trend, again, they need treatment. Then absorption of levothyroxine may be decreased if it is given with soya formula or iron and calcium. That should be kept in mind. Levothyroxine dose, initial treatment started with actually at following doses, given once with 0 to 6 months, you have to give 10 to 15 max per kg, 6 to 12 months, 7 to 10, 1 to 3 years, 4 to 6, 3 to 10 years, 3 to 5, and 10 to 16 years, 2 to 4. That means they need a bit higher doses in comparison to the adult person. Alternatively, the replacement dose can be calculated as a function of body surface area, that is 100 mics per meter square per day. A narrow therapeutic index effect for the brand variability, the minimum a 1 hour gap for the food intake and 4 hour gap with other vitamins and calcium supplementation could be emphasized for particularly once you are starting with replacement therapies. How we are going to monitor? FT4 should be kept in the normal upper half, and FT4 or T4 should be the upper, that is mid to upper half, and TSS should be kept in the lower normal range between 0.5 to 2 is okay. Once proper dosing is titrated, then follow-up should be done every 2 monthly for first 6 months, then every 3 monthly for 6 months to 3 years. Then after that, every 6 monthly thereafter till the completion of growth and puberty. Once growth and puberty is completed, then once in a year evaluation is also sufficient in those group of patients. So TSH and FT4 should be checked every once in a year once someone has completed growth and puberty tests. So a early and adequate treatment with levothyroxine prevents neurocognitive deficits at the age of onset less than 3 years. Adequately treated children will have a normal growth, puberty, and fertility. Drug compliance is an important aspect that to be addressed in particularly children's. Regular dose titration, growth charting, and bone age assessment is utmost important. Requirement is reassessed after puberty and dose titration is done according to the adult protocol. Bone maturation is not advanced, confirming that treatment regimen has not induced overt hyperthyroidism. As there are various clinical presentations, early diagnosis can help to avoid unnecessary investigations and patient's anxiety and treatment for the complications. With this much, we are finishing. Anything we can discuss or any topic, any questions we can discuss now.
Thank you, sir, for your wonderful presentation. So, we do have some questions if you like to take that up.
Yeah, no problem.
So, sir, the first question is What are some of the less common clinical manifestation of juvenile hypothyroidism?
Probably in all my case presentation, I have shown you some of the rare presentations how this present, because if you see each and every case what I have shown, these are the rare present. That means a primary hypothyroid having enlargement of the pituitary cilia. That is rare presentation. If the 4, 5, 6 year old hypothyroid presenting with having periods at the age of 4, 5 years, or a 4, 5 years child or girl child having a breast development. This is rare presentation of hypothyroid. Another important thing is that short stature, significant short stature, that is another print hypothyroid, another classical common presentation. And sometimes hypothyroid presents with, we know the hypothyroidism presents with diarrhea, no, constipation. But sometimes when hypothyroid is present with celiac disease, sometimes they also present with diarrhea. So these are some atypical presentation like pseudo muscle hypertrophy, calf hypertrophy, then enlargement of the cilia, short stature, precocious pseudopuberty. These are those some of the atypical or rare presentations what classically I have shown in my each and every individual case series.
Thank you, sir. The next question from our audience is: what are the common conditions that may mimic or coexist with the juvenile hypothyroidism, leading to diagnostic challenges?
Yeah, as actually I have shown, the diagnostic challenges actually just diagnosing hypothyroid is not important. The problem is if someone is frank hypothyroid, you can start treatment. But if someone is having subclinical hypothyroid, this subclinical hypothyroid may be due to this, could be subclinical hypothyroid or it could be secondary hypothyroid. So that is the diagnostic challenge. If you are having secondary hypothyroid, then also you should evaluate other hormones, like you have to evaluate cortisol, you have to evaluate growth hormone, you have to evaluate the sex steroids. So that will give a clear-cut idea whether it is a partial pituitary insufficiency or a complete pituitary insufficiency. Then second challenge, diagnostic challenge, is I have clearly shown, because a lot of the time people takes vitamins which contains biotin. If someone is taking biotin containing vitamin, that biotin interferes with thyroid assay. So that will happen, you will get a wrong report. Despite of a adequate replacement, still TSH is high. So in that case, you have to predict that, you have to stop biotin for at least 72 hours. Then you have to reassess, or you have to do again, do a thyroid function test. That will give a clear-cut idea about it. If someone is having a type 1 diabetes, if someone is having celiac disease, if someone is having hypoparathyroidism, these are also people who are prone to develop hypothyroid. Despite of absence of any symptoms, they should be actually exposed to do a thyroid function test, because a lot of the time in type 1 diabetes, in hypoparathyroidism, in celiac disease, in vitiligo, those having pernicious anemia, these are the group. Again, hypothyroid is a quite common association. So even if there is no classical symptoms of thyroid is there, one should evaluate those patients for hypothyroid. So these are the common typical associated conditions what we get, and one should be very much clear in their mind that if such group of people are coming, we should evaluate for hypothyroid.
Thank you, sir. There is one last question from our audience. Are there emerging diagnostic or treatment modalities that show promises for involving outcome in a typical case?
Oh, actually, one should be very much clear. This hypothyroid is a very easy disease. If we are diagnosing properly and if we are starting the treatment with a very cost-effective way, the patient can be managed. Because we know that if someone is having thyroid hormone deficiency, replacement of thyroid hormone is the best modality of treatment. A subgroup of people will come where actually, despite of giving all sort of replacements, still patient is complaining of some sort of symptomatic thing, like I'm having myalgia, I'm having muscle pain, I'm feeling weak, I'm feeling fatigue. In those subgroup of people, you can give T3, because now T3 liothyronine is also available as a tablet. You can give this T3 and that will give some sort of symptomatic improvement. But frankly speaking, if someone is taking levothyroxine replacement, that is sufficient for up to 99%, and 99% patients, everybody get symptomatic improvement, clinical benefit, biochemical benefit, everywhere they got benefit, only levothyroxine replacement. But a subgroup of people where classical symptoms is there, in that case, you can think of adding this liothyronine tablets, and that will give some sort of clinical benefits in those group of patients. Otherwise, levothyroxine is sufficient for each and every person.
Thank you so much, sir. That's all from our audience, sir. And before concluding today's session, sir, any last remark from you?
Well, the remark is if someone is having as a young child, if someone is having short stature, if someone is having a family history of hypothyroid, if you are someone having a goiter, if a child having associated with any sort of autoimmune disorders, a thyroid screening is utmost important. A thyroid screening should be done in each and every patient, because we know hypothyroid is the most common cause of reversible cause of mental retardation. It is the most common reversible cause of short stature. So if we can diagnose early in short stature cases, if we can diagnose early in mental retardation cases, probably we can give a significant benefit to this group of patients. So if in those subset of patients, a thyroid function test should be done early in due course of time.
Thank you so much, sir, for joining us today. And thank you for answering all our questions.